So let's start with the pathophysiology of intracranial hypertension and head trauma. Here, so what for me it's important that you understand, that you get the logic between every disease, every pathology. So if you understand the basic concepts of every disease, if you understand how it should work, then it's easy for you to understand the pathophysiologies of this. So, for example, the topic that we're supposed to cover is pathophysiology of intracranial hypertension, head trauma, and for that we need to understand two basic points. One is what is the pressure what is the pressure in the brain, from where it comes from, and then we can actually understand the pathologies, right? So let's say, so here we have that the pressure comes from the skull, right? So if you think about it, we don't have any room for to have an inflammation. So that's when you have an inflammation in a muscle, when you have an inflammation in one of the organs, you have room to grow. But if you have an inflammation inside of the head, inside of the skull, you don't have any room, and that changes in everything, in the blood volume, in the CSF volume, or in the tissue volume. It will affect the tension, the pressure of the brain. So we call it, when we have a change in any of the three things that I just mentioned, we have an increase in intracranial pressure, and this is a very difficult treatment condition that happens when there is an imbalance between your brain tissue, cerebrospinal fluid, and brain blood volume. Do you know what is your blood pressure?
8120.
8120. So as that is a very common knowledge. This is for example, our normal intracranial pressure is below 15 millimeters of mercury. So if we are below that, or brain is okay, or liquids in the brain are okay, the tissue, the mass in the tissue, it's okay. And then if we have above 20 millimeters of mercury, then we have a ICP. Okay, so we start from there. And then what do you think that can affect any of the three? Who could give me an example of these three causes?
Maybe the drainage of the cerebrospinal fluid is not working properly.
Okay, that could be one. Yeah. So that would mean more CSF in the head, right? In the brain, and that's how it's called that. how is called when you have more CSF in the brain? It is called hydrocephalus. And so we have this condition that are called like hydrocephalus. Is mainly in children and something like this. What else? What else could cause that or that we have intracranial hypertension?
An edema caused by trauma.
Trauma, okay. So that's actually what we're going to talk today. That is the edema, cause how that affects the brain. What else?
A tumor.
A tumor. Yeah, exactly. So if we put something else that shouldn't be there, also that. But how can we have like this blood volume increasing?
Maybe in a hemorrhage. But I don't know.
Hemorrhage. Yeah, it could also work, but also if you have hypertension, right? If you have more like an increased tension on the blood, and then if you have dehydration, and then you have more thickness in your blood, for example. So these are physical causes that could generate that you have more pressure in the blood, more blood in normally in the brain. So let's start from the head trauma, and then if we talk about head trauma, that is part of the syllabus, but what is actually here is the traumatic brain injury, right? TBI. That's what we're gonna talk today. And there are two things that there are many things that we need to consider here. And the problem is that when for example we hit our head, we have something that is called the coup and the counter coup injury. So if you think of our brain as a gelatin inside of a bone, right? So what we have is that it's some mass that is floating in our brain, in our head. So the problem is it doesn't have any structure. It doesn't have a bone in the middle that could actually sustain it. So every time that you are hitting the head or anything, you first have something in like the damage in the front, but then when you have this inertia coming back, then you have also in the back, and that's the problem. Then sometimes, you don't have to only worry from the first part, but also for the second part. And of course, how difficult or how bad is the TBI, depending how bad was the injury, right? We're talking about head trauma. We're talking about hits in the head. We're talking about where exactly in the head are we're having these hits. Okay, so for example, here is saying, okay, there might be a skull contusion, a skull fracture affecting the cranial bolt of the base of the skull, or a concussion or brain contusion, an injury to larger size of blood vessels, for example, producing an hematoma. And this is what we're gonna check today. So the clinical manifestations when we're talking about TBI, we're gonna divide them basically in mild or moderate and severe. And one of the problems is the when you have impaired consciousness because of the hit that you had in the face in the head, that it goes with memory deficit. So do you know what is retrograde or anterograde amnesia?
But you can't remember what happened like before the event is retrograde, and what that you can't create the memories of what starts happening is anterograde, I think.
Exactly. So basically, one is what you like the you can forget what happened just before the hit. You can forget about it, and then you can also forget, or it's difficult to create new memories, but also you're forgetting things before that happened. So, for example, here we are also talking, or we talk about this before, that if you're activating, you could activate neurons because of a trauma, and then that can cause a seizure, for example, or it can cause that if you, because of the impact, you can get actually more cognitive problems like memory problems later on. So, for example, here it's showing for TBI, if you have the heat, you have nausea, vomiting, dizziness, balance issues, headaches, confusion, sleeping less or more than usual, and anxiety. And then when it's more severe, then we have the problem of the losing of consciousness, issues in the hearing and vision, trouble communicating, and changes in sensory and perception. So, and these are part of how we are going to detect how bad it was the hit in the head. So, does anybody have actually like experience something like this when hitting in the head? Nobody has hit in the head. Who is practicing any sport? I mean, I think some of you are practicing. Which is the sport that like you practice? Like not like a more. I'm not gonna say professionally, but maybe more in that line, not recreationally, for example.
Well, I don't know if it's recreationally, but I mean, dance team
Dancing.
from tech, and we do some skills that often require like a lot of motion, and sometimes we actually get hurt a little bit, but not that much. Like you could get a hit in the head trying to do a trick in this dance team.
Okay. Have you had?
Not in this dance team, but in another dance team that I was, yeah, I got a hit in the head. I was doing a spin and I slipped and I fell on my back and I hit my head.
In this case, you hit first the back and then
Yeah, the back of my head.
yeah, that's actually that's more. Did you lose the consciousness?
Not in that occasion, but there was another time that I did lose consciousness. It's because I tend to like get a lot of hits
Okay,
dancing and doing
okay,
things. So yeah, there was
okay.
other time. I don't remember if I
Yeah, that
actually
that
lose
that that
consciousness.
sounds
That's the
good.
thing.
Like that explains. If you don't
I
remember
cannot
now, it's
remember.
too many hits, I think. No,
Yeah,
no,
I think
I'm
people were worried because I cannot lose consciousness for like a second, but I cannot actually remember if
yeah,
I actually lose consciousness or not.
yeah. So that's actually one of the things of the clinical manifestations that we cannot trust the patient actually because you don't remember. I mean, that's the whole thing, and that's why witnesses they have to be there. So I was a kid, and I was very into Spider-Man, and then I tried to climb my house with an old rope, and then the old rope broke, and then I hit my head. But nobody saw that. So I just have I think I have a fracture here in the skull. And that it actually nobody saw. I was afraid of my parents at the time, so I didn't tell them. But since that moment, I have here kind of something that is it shouldn't be like this, I think. But nobody saw it. Nobody. Somebody was taking care of me, and they didn't see. So there is nothing, not information about what actually happened to me, and because I don't remember, I just remember that it just broke, and then I hit my head, and that happened. So this is it's important. So Andrea, I would say, let's avoid sports that require more hitting in the head. That would actually help. And and I'm gonna explain why. I mean, we need to know why. I mean, what is the problem with this? There are, and of course, depends how severe is the damage that you are getting in the head. Okay, we can actually classify them in different I mean, redundancy, but with different classifications. But we have brain injuries that they are considered closed or open, depending if the dura mater it's intact or not. So if it's intact, then it's better to an extent, and than when it's exposed, when the brain is exposed. Then we also have that depending where the damage is in which part of the brain. So if we go back here, for example, no, I think it's not. I have another one here. Wait, where it is? Yeah. So for example, here, if we're talking about the skull, we have the epidural space, the dura mater. This is the epidural space. Maybe I don't know if I can. Do you see this part here? This is the epidural space. This is the dura mater, the subendural space, the arachnoid space, meninge, and then subarachnoid space, and then we have the brain. So as you can see here, depending where you have you can have damage in any of those different space, and that will also define how good or bad the prognosis of the damage is done. And that's what I was saying. No, depending where it was, how big the hematoma that is forming in the brain is happening, then it will have different effects. For example, how can we recognize this? Is the duration of unconsciousness. Let's take as an example Andrea. She said that it was a second. Let's say they might say the same. The people that was there. The duration of amnesia. So if you remember something before that. I mean, you remember, I think, everything. Andrea.
Yeah, I just remember that I feel I hit my head, and then like for a second, I don't know, like I was confused.
Yeah.
And then like I just saw everyone was worried like ahead, like in front of me.
Yeah. So that actually the confusion is also something that is very common, and like you can also have epileptic seizures, for example. And the worst is when you're getting bleeding from the ears or nose. That is basically the first things like on site, what the doctors or the medical team needs to check. And how bad or how good are you is depending of this Glasgow coma scale. So, and these are three things that they need to be checked when someone hits the head. Is if the eye opening, like they are actually responding to spontaneous movements, to sound, to pressure, or it's actually just totally lost. If there are verbal responses, so these things that actually happen in the movies, right? That is like, can you tell me which dates today, what you were doing, etc., etc. And then if you have a motor response, normal flexion and abnormal flexion, they can follow everything, or there is nothing. So if you are in the worst, then you have only 8 points in all of these. Moderate, if you have between 9 and 12, and it's mild if you don't reach everything. So, I mean, mild between 13 and 15, and then all of the others should be all the points. Yep, so that's how this Glasgow Coma Scale works. And what we need to check here, or the doctor checks in the imaging studies, it will actually tell you where the damage is happening, and this is where we are going. So we have first with the head and spinal CT scan, we're going to see if there's a fracture in the skull, if there is intracranial hemorrhage or brain contusions or cerebral edema. MRI is not always that easy. Cannot be used for diagnostics, and the EEG we need to do it quite fast just to see if there is not epilepsy, or that is a generalized slowing of the brain. So the assessment of severity based on what I told you in the score of Glasgow's coma is maybe if we say mild, it's going to be loss or impairment of consciousness lasting less than 1 hour. Moderate, loss of or impairment of consciousness lasting 1 to 24 hours. And severe, like this is more a coma state, unconsciousness for more than 24 hours, or any brainstem signs. The neurological findings is confusion, amnesia, encompassing the traumatic event, and focal neurologic deficits, cranial nerve deficits, epileptic seizures, or intracranial hypertension. So the question is why? Why we have all of this? Why we could have all of this? How, in the worst case scenario, a hit could affect, like, what is happening in the physiology on the brain? That's the question. So we started from an action potential to neuronal waves to seizures, and now we're hitting the brain. We're hitting the heads and we're hitting the brain.
Well, I don't know if that's kind of logic, but I think you can literally like move the brain, right? Like you can have this like movement that is causing the nerve damage and the like damage in the blood vessels because of the impact. And like well, this is just an example that comes to my mind, but when they say that you agitate a baby like really, really hard, you start creating a hard movement in the brain that affects due to the impact that it's causing, right? Because the brain, yeah, like we have things that protect the brain, but not if you are constantly moving like at a really hard speed. I don't know.
Yeah, the skull shaking syndrome for the babies, and it's the same. I mean, it's so yeah. I mean, in general, yes, you have that is. There is just something that the problem is that we don't that you mentioned, but I don't totally agree. Is that we don't have anything to actually protect our brain. The thing is, I mean, we have the liquid inside that actually protects a bit for some stuff, but then we don't have anything. I mean, what do we use to protect our brain?
The meninges.
The meninges as well. Yes, that is more a protection of, yeah, the thing is like neither the liquid neither the meninges are like designed for protecting against something as difficult as like a heat, right? So that is something very bad. I mean, nothing in our body is actually protected against that. But what is the problem with the brain? What is actually, I mean, we could talk about the blood vessels, but what is actually happening to the neurons?
Maybe if there's like ischemia, they're like dying.
No, but not even there. I mean, it doesn't need to reach to ischemia to actually reach that they start getting affected or getting or dying. Actually, just because of the heat, just by the mechanical heat, you can get that some neurons, because of the shock, because of the mechanical shock, they can start dying, and that's not okay, right? That's one of the points. It doesn't actually work like that all the time, because how can we define the inflammation of the brain?
In the intracranial pressure that it occurs. But like
How
you
how
need to
can
have a CT or something like that, right? Like you need to have an image that proves
okay, that's for
that.
diagnosis, but how is our
Okay.
brain getting inflamed? What is neuroinflammation? Maybe let me see.
I'm gonna be completely honest, I just searched it because I didn't know. But they say that it's mediated for glial cells,
Which ones? What it says there?
microglia and astrocytes.
Microglia and astrocytes. What are microglia?
The cell that like this is the immune cell, right? On
Yep.
the nervous system.
Yes. Who doesn't? Who knows about this?
Can you repeat?
What is the what microglia is doing?
It likes wait, I forgot the word in English. Give me a second.
Yeah.
Is it like phagocyte?
It's yeah, thank you. Yeah, it's the things that they don't that they don't need to be in there, like
Yeah.
como un macrófago.
Yeah,
Se me
exactly.
olvidó la palabra.
Exactly. That's they are the macrophages of our brain. So we don't have macrophages because we have the blood-brain barrier. But then we have these amazing cells, and I'm gonna say amazing because my lab, what we're doing is we are very focused on microglia because we don't know all the things that they can actually do so far, and that's very very interesting, and we're really into that. But I'm gonna show you a video, and then let's see if that helps us a bit to understand. You let me know if you can hear.
And this is your brain on neuroinflammation. Of course, brains rarely literally catch fire, but inflammation in the brain is more common than you may think, and it may even contribute to mental health problems. Today on the Elements of Science, I'll show you why. We say the brain is inflamed, we mean that its immune system is overactive. In a healthy brain, specialized immune cells respond to infection or injury. If you're on the wrong PowerPoint slide at the wrong time and sustain a head injury or get an infection in the nervous system, a rallying call goes out to recruit immune cells to clear out pathogens and any damaged tissue. And this is a good thing. But sometimes the immune cells don't get the message to stop, and they damage brain tissue. When this goes on, it can become chronic neuroinflammation. You can't directly see or feel it, but it interferes with the way the brain functions. Chronic inflammation can happen after an injury or illness, but other things too, like chronic stress or even just getting old, can trigger out-of-control inflammation, and it does a lot of damage. Inflammation contributes to many neurodegenerative disorders, for example, multiple sclerosis. Normally, the brain's immune system is actually separate from the rest of the body's immune system, but in MS, immune cells from outside the brain break in and attack white matter. Neuroinflammation may also contribute to Alzheimer's and Parkinson's disease. And although the processes are different, leading theories about these diseases suggest that abnormal protein deposits trigger inflammation in the brain, leading to a vicious cycle that ultimately kills neurons. Chronic inflammation is also present in some mental health conditions, especially depression. Many patients with depression show increased inflammation in both the brain and the rest of the body. And depression, of course, has many different causes, but this inflammation may be a factor. Levels of inflammation may even predict which treatments will be effective for different patients. All right, so sometimes the brain is inflamed, and that may contribute to disease, but what can we do about it? Well, some drugs can reduce neuroinflammation, and one surprising newcomer to this group is psychedelics, like psilocybin and LSD. Although it's certainly not what they're known for, psychedelics have rapid anti-inflammatory properties in the brain, and especially when combined with their potential ability to enhance neuroplasticity in certain brain regions, this makes them a potential.
Okay, I don't want you to think that LSD is good, so that's just research that is happening right now. I don't know if actually, I mean, there is a lot of people working with LSD right now. We actually use it in our lab to actually test inflammation, but it's not. Yeah. So what I want you to see is that actually the inflammation will be traduced to, maybe I can show you here. Wait. it's going to put the whiteboard. So basically here what we have. So basically what we have is that the microglia, they recognize pathogens, and then they are all the time like surveilling the brain. They are surveilling the brain. For example, we have a neuron here, and then they are in charge of checking that everything is okay. And there is a theory that is called that we have M1 and M2 microglia, which means that M1 is more homeostatic and that is going to protect our brain, and it will help us to maintain like that the neuron has energy, that the neuron can actually prune the synapses and maintain the synapses in the best way possible. But then we have the M2 that they are pro-inflammatory, and this M2 what they do is actually generate what it was showing in the video, that actually start attacking the cells and then they start destroying them. So what is happening is if you are actually hitting the head a lot, then you will have an hyperactivation, a chronic activation of M2 pro-inflammatory microglia that will, instead of helping to clear and to maintain the cells, it will start damaging. That's what they were showing actually in MS. In MS, who is more into that are the astrocytes as well. So that is, for example, what I wanted you to have an idea of what's actually happening with microglia and what is happening with the inflammation of the brain. So all of that will happen because of something, MS, Alzheimer, or because you are having a damage in your head. Okay, so let's go back to this. Questions so far? No, okay. So the pathophysiology of the what is happening in our head will depending on the type of injury that we're having. Okay. So we have these subtypes, and actually I want you to explain what would be the pathophysiology of it's going to be a bit complicated. So what happens here is that depending, for example, in an open head injury, what you will have is that the dura mater is breaking, right? And then if that is breaking, we have two main things. We can have an herniation of the brain, which means that the brain tissue starts escaping. But also what you can have, what will happen if you have an open, what will be something that you will need to take care?
There would be a greater risk of infection.
Infection, meningitis, for example. And that's more important and more difficult to control. So that is the pathophysiology when you have an open versus a closed head injury. If you have a head injury, that like a closed head injury, we are going now to the next step, right? So this in this case, in this pathophysiology, just think that if you have an open injury, then you will have problems with infections. You will have problems with. Do you think that you will have problems with the pressure? Andrea said yes. Why?
Because of, first of all, I think the infection actually is going to affect blood vessels, astrocytes, as we already said. And because of it may cause swelling that leads to things with pressure.
What do you think that will happen to the liquid in the that is around the brain, the CSF?
It's going to start producing more.
It's going to start leaking. If it's open,
Okay.
it will start.
Yeah.
It will start lucid. So that it will actually generate problems, tension in the brain, that it won't help to maintain the nutrients that or brain demands. So those are the problems of having an open head injury. And then if you have a closed one, then we will have problems with the pressure. That's one of the things. What do you think? What do you understand from a skull contusion? What can happen to our skull that is not breaking completely? What happened to me?
Yeah, you have a little I forgot that's in English, but fissura.
Yeah,
Fissure.
You can have a fissure. You can have a fracture. So that's something that happens, and it's not the worst if that happens. It can actually heal by itself. What would you do to let some your skull to heal? If it's not totally broken, I mean, it's just a partial fracture, like nothing very serious.
Like maybe just protecting the area so it doesn't get worse, like avoid hitting again in the same spot. I don't know.
That would be good. Yeah. And actually just not moving. I mean, just avoiding moving for some time, like bed rest. That would help a lot for that. And then we have something that is called diffuse axonal injury. And that is something that we kind of saw like now with MS. If we have problems because of the inflammation of the brain affects the axons. I mean, that's like a secondary effect of the heat or everything. Then you will have kind of the same problems as you have with the motor, with MS, with the motor problems, sensation problems, etc. And then we have, so these are bringing us to what is concussion, what is brain concussion, cerebral edema, and brain compression and herniation. So the first three are quite easy to understand, but when we are talking, for example, of a concussion, this is what we can happen. So, for example, most likely what Andrea had when she fell, it was a concussion, because this consists of a brief period of unconsciousness, generally no more than a minute, few minutes, and then you're a bit confused. Periods of retro and anterograde amnesia, brief, and can come with a headache, dizziness, nausea, and vomit. This is important, and I don't actually agree with this, that it says that there is no neurologic deficit, which says that there is not a structural damage in the brain, and that, but for example, they also mentioned that with MRI, they reveal evidence of axonal damage in some cases. So what is happening is like, this is the way, or this is why people doesn't take serious the concussion, because you can continue with your life, you can do whatever, but the problem is that all of that is kind of leaving a mark for the future, and this it should also help to kind of maintain better, like, the brain is your most important organ, right? I mean, if you start losing your heart, then you die. That's it. But then if you lose your part of your brain, then you start losing function by function. And I think, I mean, I am a neuroscientist, but I think that's more important in that sense. I don't know. If you ask to a cardiologist, they will say that the heart is the most important thing. I don't know, Estrella, do you wanted to say something? No? Oh, good. Okay. So this is the difference, right? A concussion, it's like brief period of unconsciousness and not neurological deficit. That's what I want you to get from the concussion. Brain contusion is not the same. Here we're going to talk about basically damage in the brain. Concussion, just you don't know where you are, just lose a bit of what's happening. Reset in the brain. Contusion, you are having damage in the brain. Okay, and this, for example, is when it happens, you have a long period of unconsciousness and retroanterograde amnesia. The patient might not remember anything for a period of several days. So this is getting worse, right? We need to find out when the problem is happening. So here, for example, we have bleeding. This is this is how it looks in the temporal lobes, that then you have blood here. This is how it looks in a CT scan. This is another CT scan, but this is for the what's the name? The epidural. This is what's the name? Epidural hematoma. Yes, this is an epidural hematoma. Here's where you have the hematoma. It shouldn't be there, but then you are pressuring the brain from the outside. And what the problem of all of this is actually that patients are they are losing brain tissue, right? So if we go back, I mean, we're talking about the concussion, that nothing happened. You just got a bit of inflammation. You got a hit, and then you got then you have a brain contusion when you are actually having damage in the brain, and this is linked to the cerebral edemas. And here we have a way to actually understand the different types of cerebral edemas, and that will lead actually to brain compression and herniation. So depending of the cerebral edema that we're talking about will depend the severity of the injury.
I have a question.
Yep.
I didn't quite understand in the concussion, if nothing really happens to the brain, then why do you lose consciousness for a little while?
Exactly. I mean, that's actually this is, I'm showing you what is in the book and what it says, but if you are losing, let's go back to the waves, right? If we go back to the waves, like you have in this sense, you have an epileptic attack or a seizure. What would you think that it happens when you have a concussion?
Like the same excitatory discoordination of the neurons.
Exactly. You have a disconnectivity in this case that is actually affecting the parts of the brain that they are. If you remember, and this I said that I will put in the quiz, but if you can affect some parts of the brain that are related to the consciousness. So it means that you lost the synchrony and the connection with that region for a moment.
So it's sort of an absence seizure.
Exactly. I mean, it would be. How can I explain this? So we talk about the how the brain generates action potentials, right? We talk about how the brain needs to synchronize to generate the functions in the brain. The next thing is, if we don't have communication between the different regions because of whatever, because the loss of a neurotransmitter, for example, if you have if you have a loss of neurotransmitter, or you have an increased inhibition in all of these neurons, you will get that the function of each parts of the brain are not actually working, right? And in this case, just because of a heat, you are losing all the synchrony and the action potentials of the brain. Like, so you're having that the brain, when it's hit against the skull, all the connectivity between the different parts, like the excitatory, inhibitory, etc., got interrupted for a second. For some reason, the neurons cannot actually communicate. So if we think about a comatose event, like if the people is in coma, what you don't have is actually communication between the neurons. And in this case, this is what happens very, very, very fast. And this is why I don't agree with this, because you are losing something, and that can generate inflammation, and the inflammation is very difficult to resolve in the brain. So better?
Okay, so it's just the heat causes desynchronization for a moment.
Yes, it's a shock.
All right.
Like we can call it a shock wave of the heat. Yeah.
Thank you.
No worse. So then when we talk about the edema, so after the traumatic event, we have that water and electrolytes enter the extracellular space. Then the blood-brain barrier collapse, and then the blood-brain barrier collapse, and then you have swelling and intracranial hypertension. That could lead to hypoperfusion and brainstem herniation. So this is herniation, for example. We talked that here, for example, the skull is broken, and then here we have that the brain start coming out. We have an extradural hematoma. So this is the out part of the extradural, and then you can have here, for example, this herniation to this side or herniation to this side, or descending herniation, for example. This shouldn't be here. So it's just where you have the brain happening in different ways. What is the problem here? Can we feel pain in the brain? Sorry, Pamela.
No, I was gonna ask you something. No.
No, ask me.
No, I was gonna say like, so that's related to the loss of the cerebrospinal fluid, or because I had understood that when you lose it, that's like it stops floating around, so it can herniate, stops floating around the brain. But I do not understand it quite well.
Why did you have an herniation, you mean? I mean, in this case, it's just because, for example, you have something pushing here, right? And then the brain start going to places that they shouldn't be, right? So in this case, it's pushing to here, or maybe because of a hit, part of the brain came into the other boveda, and then it stayed that brain tissue there. Or in this case, when it's broken, for example, this is not, I'm not saying that it's because of you can here you are losing the CSF, you are losing the liquid in the brain. That's one thing that can cause hypotension in the brain. But then you are also getting here. So I'm when I was talking about that, imagine if you have a smaller like fissure here, and then you start the CSF start leaking from there. So instead of having something that is compact, it's open, and then you start losing liquid from the brain. And in this case, what happens is that just because there is a way out, and then something else can be pushing, or just because gravity or whatever, then your tissues start coming out. That doesn't look very, very nicely, but I don't know if I explain myself. Do you?
Yes, I think I did understand. Just one thing, we can't see your pointer anymore.
No, sorry. Yeah. Okay. So there's different things, and the problem with this basically is the different subtypes of hematomas that we can have in the brain. So that's what I was showing you before. These hematomas come because, of course, you are tearing small blood vessels, or big vessels also in the brain, and then you can have it inside of the brain. You can have it in subdural, so subdural here, subdural space, which is gonna affect like more the brain. Here you have an epidural hematoma here. Here, for example, this is what I was saying before. If you have a fistula of like a small tear, and then the CSF starts escaping, and then you have meningoencephalitis, for example, or even can cause because of the whole broken part of the skull. You can get even epilepsy, or what we were showing before, this herniation of the brain. So imagine that you have a bunch of neurons, and then you just push them, and then what do you expect that it happens? You will activate them, but the big part is that in the brain itself, it's not gonna feel pain. So that's why it's complicated to imagine that all of this can be happening in your brain and you are actually not feeling it. How would you treat these patients? Imagine that you are the neurosurgeons or the doctors or everything. How would you treat them?
If it's an open injury, I would start them on antibiotics.
Okay, that's one. Good. What else?
I don't know if this is true, but or if this applies to this, but doesn't it sometimes when the pressure is like too much, they like open a hole in the skull to relieve some pressure?
Yeah, that's a craniotomy, and it's because of that. But then, what is the whole thing? Like you say that no, it's to reduce the pressure. So we need to find. I mean, if we're talking about closed or even in the open TBI, we need to reduce the pressure in our brain. Okay, and that different way. So the treatment that we have basically, and actually, here is where I got again into the artificial ventilation or the hyperventilation that I tried the other day to explain to Estrella, but it was a bit complicated. So basically, we need to administrate isotonic fluids. We need to sustain a blood pressure that is at least 120 millimeters of mercury. But what we need to try to do is to reduce that pressure in any way. So we're going to check different things. Something else that we need to do, of course, antibiotic is something open. And then we need to intubate and to be sure that there is enough oxygen to prevent hypoxia in the brain. And then, of course, like in many cases, the patients, they have to be sedated to be without moving for a long time. So normally what happens is the elevation of the head when you are in the treatment, adequate oxygenation, restoration of the energy in the body, sedation if it's too bad, what's happening. We're going to talk something. Then we have hyperventilation if the patient is intubated to lower the CO2 in the blood. Drainage of through catheters, hemicraniotomy when this is too bad, for example, or even bringing the patient to hypothermia. So this is what happens. I mean, this is what I wanted to show you, and this is actually, I didn't expect that we needed to go to here, Estrella, that it was, again, trying to talk about how we can have hyperventilation. But all of this comes to how can we actually reduce the intracranial blood pressure. So here we're going to talk about how the volume control of the blood can help us to treat these patients. For example, we need to first stabilize the patients. So we need to check what is the cerebral perfusion pressure, which is defined by the mean arterial pressure minus the intracranial pressure. In individuals, the CP is above 60 to 100 to 80 millimeters of mercury. And when this falls, the blood supply in the brain is compromised. The brain is damaged not by the mechanical pressure, but also by not bringing enough oxygen and not bringing enough energy to the brain. And that happens when we have less than 60 millimeters of mercury. And that's what happens when we open the scalp, right? That's what one of the things that when we start losing the CSF, when we start losing blood, when we start losing that is going to happen. And then if you don't have enough oxygen and you don't have enough energy, then your neurons start shutting down, and then we have this unconsciousness. So this is how we call it hypoperfusion when it's less than 60 or around 60, and then we have severe hypoperfusion when it's 40 and 80. We can say that is quite normal. So to treat to bring this to the way that it should be, so we have different ways to do it. One is using something that is called mannitol. That is, it's a sugar alcohol that is osmotic diuretic to reduce intracranial pressure and cerebral edema. Mannitol causes an increase in serum osmolality and osmotic gradient between the serum and the intracranial component, with subsequent removal of rainwater to reduce the intracranial pressure. The hypertonic saline, this mechanism actually is similar to mannitol, but we need to create this anosmotic gradient between the serum and the intracranial compartment. So here we have this image where we need to. There is something to actually talk about this. There is an example when we need. What happened when we when you eat too much salt?
Hypertension.
Yeah, and then what is something that you can measure with the when you are eating too much salt? Like what is one of the symptoms of the hypertension? Okay, another. Do you know what do you know about diabetes? Which are the triads of the symptoms that you have?
Polyuria and polydipsia.
Okay, polyuria. Why polyuria?
I don't really know. I just know they like drink a lot of water and they like make a lot of pee.
Why?
I believe is because of the osmolarity of the urine. When there is an increase of glucose, well, the water follows, so they excrete glucose as well.
Yes, but where you are also getting more glucose, not only in the urine,
And the brain.
in the brain. What else? Where can we
Well, in
measure?
general, everywhere, right?
In the blood, right?
Yes.
So if you remember what happened with osmolarity, we will have that the liquid needs to, like in all of these things, the liquids will follow where the gradients that it's more concentrated, right? Or sometimes we have parts that they will go that will transfer, like I was explaining before with the ions. But in this case, you can see here that the water will actually, if you have an hypertonic saline solution or you have this drug, then you will have, or if you would have more glucose, you will have that. Then the liquid, the water, will try to compensate these parts, the concentration between the extracellular or one part, in this case is the brain, and in the other is the blood. And with this you can actually reduce the intracranial pressure. And that happens with the hyperventilation. So I took a bit of more time, and here it's just going to be 2 minutes. Yeah, we're not going to have time. But anyway, so the hyperventilation, what we need to do is to reduce the CO2 in the blood. For that, we need to remember what's happening with the CO2. All right, the CO2 is what we are producing after the mitochondria are generating ATP. And this is an acid waste product dissolved in arterial blood. So the normal pressure of CO2 that is called normocapnia is around 35 millimeters of mercury and 40 millimeters of mercury. If we use hyperventilation, we can actually bring the CO2 to 32 millimeters of mercury, or 34 transiently, because then we need to go back to the same. Otherwise, you will generate an effect. And this is what happened. So, no, sorry. So if we are hyperventilating, we will have more oxygen in our veins, right? That's what I tried to explain the other day to Estrella. And then we have that the CO2 will reduce because of this hyperventilation. So if you have this hyperventilation, then you will generate this vasodilatation in the blood vessels. But we cannot actually maintain it for too long, because that means that you will have less also blood coming to the brain. So it's very, very dangerous to go in full hyperventilation for a lot of time. But this is actually why we can manipulate the CO2 and manipulate the vasoconstriction and the vasodilatation of the blood vessels. And then we have the induction of coma, 2 minutes. And in this case, what we can do is just to reduce the metabolic demands of the brain in a safe range. We're going to maintain the patient without moving. So because agitation increases pressure and increase the ICP, and then we can use something like propofol or barbitures to induce coma completely in the patient. And so normally what happens if the injury is too bad, in the meantime that the pressure of the brain go back, and then we resolve the bleeding and the hematoma of the patient, it's very common to bring it to a state of coma and then leave that to happen. So this is like how the patients are treated. It can go to prophylactic measures, resection of mass lesions and CSF drainage, hypersmolar therapy, as we were talking, hyperventilation, therapeutic hypothermia, barbitures. This is when we get into coma. And then at the end, we can have the compressive craniotomy. So this is how the target that we need to reach to have intracranial pressure lesser than 22 millimeters of mercury. So then we're gonna talk about chronic traumatic encephalopathy for the next class, and this is actually we're gonna talk about tau and Parkinson's disease. So for the next class, what I want you to read is basal ganglia. Okay. This is not going to be part of this is not part of this chronic traumatic encephalopathy, but I want you to tell me. So I'm going to show you. I'm going to show you quickly an image. So this is the basal ganglia, and I need you to tell me which are the function of this nuclei in the brain. Okay? Caudate, nucleus, thalamus, globus pallidus, hypothalamus. If you come with this read already for Monday, it's gonna be for me easier to explain you what is the Parkinsonian syndrome, what is a Parkinson's disease. Okay? Questions?
No, thank you.
Sure? All good? We're gonna have a recap again about what we were checking. Sorry. Okay.
Can you please upload this presentation and the videos, please?
Yes, I will do it. I tried the other day and then I couldn't do it, but I will do it soon, as soon as possible. Okay, then no questions, all good?
Me, but it's a personal thing.
Okay,
Me too.
okay, we can have 5 minutes. Yes, I mean, okay. So how do we do? Separate. It's. Do you want to go to another? How's it called? Okay, I'm gonna stop the recording.